students, today's class we will see about the respiratory distress syndrome, otherwise known as hyaline membrane disease of newborn. Respiratory distress syndrome, formerly known as the hyaline membrane disease, is a syndrome of premature neonate that is characterized by progressive and usually fatal respiratory failure resulting from atelectasis and immaturity of the lungs. RDS occurs most commonly in premature neonates, primarily weighing between 1000 and 1500 gram and between 28 to 37 weeks of gestation. In neonates, 28 to 30 weeks of gestation, the incidence is 50 to 70% and increases with the degree of prematurity. RDS can be fatal. Those who survive are at risk of chronic respiratory and neurologic complications. Pathophysiology and etiology of RDS. Adequate pulmonary function at birth depend on adequate amount of surfactant, that is a lipoprotein mixture, lining in the alveolar cells, which allows for alveolar stability and prevents alveolar collapse at the end of expiration. Adequate surface area in the air spaces to allow for gassing, that is sufficient pulmonary capillary bed in contact with this alveolar surface area. Second, the RDS is ultimately the result of decreased pulmonary surfactant, incomplete structural development of lung, and highly complaint of chest wall. Contributing factors are any factor that decrease the surfactant, such as prematurity and immature alveolar lining cells, acidosis, hypothermia, hypoxia, hypovolemia, diabetes, elective cesarean deliveries, and fetal or intrapartum distress that compromises the blood supply to fetal lungs, vaginal bleeding, maternal hypertension, difficult resuscitation associated with birth asphyxia. Some situations such as steroid therapy or non-heroin addicted mother result in the acceleration of surfactant. RDS due to non-pulmonary factors, cardiac defects, sepsis, airway obstruction, intraventricular hemorrhage, hypoglycemia, and acute blood loss. Surfactant production is a deficient by type 2 alveolar cells. Although some surfactant may be present at birth, it may not be regenerated at an adequate rate. Surfactant production may be reduced due to extreme immaturity of alveolar lining cells, diminished or impaired production rate resulting from fetal or early neonatal stress, impairment of release mechanism for phospholipid from type 2 alveolar cells, death of many of these cells responsible for decreased surfactant production. Intra-alveolar surface tension is increased and alveoli are unstable and collapse at the end of expiration. Functional reserve capacity, that is the amount of air left in the lungs after expiration, is decreased. Thus, the next breath requires almost as much as effort as the first breath after birth. More oxygen and energy are required to expand the alveoli with each breath, causing fatigue. The number of alveoli that expand progressively decreases, leading to alveolar instability and atelectasis. Pulmonary vascular resistance increases, causing hypoperfusion of lung. Persistence of fetal circulation right to left shunt results, leading to hypoxia and hypercapnia, which lead to respiratory and metabolic acidosis. Hypoxemia and pulmonary vascular pressure cause ischemia in the alveoli, leading to transudate in the alveoli and formation of a membranous layer. The gas exchange becomes inhibited, the lungs become stiff, requiring more pressure to expand them. Airway obstruction leads to increased hypoxia and vasoconstriction, and the cycle continues. RDS is usually self-limiting disease and the symptoms peak in about 3 to 4 days, at which the time surfactant synthesis begins to accelerate and pulmonary function and clinical appearance begin to improve. Moderately ill infants or those who do not require assisted ventilation usually show slow improvement by about 48 hours and rapid recovery over 3 to 4 days with few complications. Severely ill and very immature infants who require some ventilatory assistance usually demonstrate rapid deterioration, thus decreased cardiac inflow, decreased arterial pressure, apneic episode, cyanosis, pallor, and flaccid or unresponsive shock-like state. Ventilatory assistance may be required for each several days, and chronic lung disease and other complications are common. This is a schematic representation of the respiratory distress syndrome which occurs in the neonates. Symptoms are usually observed soon after birth and may include those listed here and increase in severity over the first 2 days of life. The primary signs and symptoms include expiratory grunting or whining when the infant is not crying, sternal, suprasternal, substernal, and intercostal retractions progressing to paradoxical seesaw respiration, inspiratory nasal flaring, tachypnea less than 60 beats per minute, hypothermia. Cyanosis with child in the room air. Infants with severe disease may cyanotic even when give oxygen. Increased need for oxygen. Decreased breath sounds and dry sandpaper breath sound. Pulmonary edema. As the disease progresses, seesaw retractions become marked with marked abdominal protrusion on expiration. Peripheral edema increases. Muscle tone decreases. Cyanosis increase. Body temperature drops. Short periods of apnea occurs, bradycardia may occur, change in the distribution of blood throughout the body result in pale gray skin color and diminished breath sounds. Secondary signs and symptoms include hypotension, edema of the hands and feet, absent bowel sounds early in the illness, decreased urine output. Diagnostic evaluations include prenatal diagnosis like evaluation of amniotic fluid to assess the fetal lung maturity, that is by lecithin spengiomyelin ratio, test for surfactant phospholipids in the amniotic fluid, phosphatidylcholine and phosphatidylglycerol, that is the phospholipids that stabilize surfactant. TDX fetal maturity assay determine the prostaglandin level in the amniotic fluid or neonatal tracheal aspirate. Lamellar bodies test measures the storage form of surfactant in the amniotic fluid. Laboratory tests include PSCO2 elevated, partial pressure of arterial oxygen PO2 will be low, blood pH low due to metabolic acidosis, calcium is low, serum glucose is low. And chest X-ray, diffuse fine granularity, white out, very heavy uniform granularity reflecting fluid-filled alveoli, atelectasis of some alveoli surrounded by hyperdistended bronchioles, ground glass appearance with prominent air bronchogram extending into the periphery of the lung fields. Pulmonary interstitial emphysema is observed in premature neonate with RDS due to overdistension of distal airways. Pulmonary function studies, that is stiff lung with reduced effective pulmonary blood flow. Management include early recognition is imperative so that treatment may be initiated so to halt the progression of RDS. In fact, treatment should be begin prior to the birth if the mother is at risk for delivering a baby preterm. Transportation to a facility providing specialized care is desirable when possible. Supportive treatment include first is maintenance of oxygen PO2 at 60 to 80 mm of Hg to prevent hypoxia, a frequent arterial pH and blood gas measurements and use of pulse oximeter, maintenance of respiration with ventilatory support if necessary. Intermittent mandatory ventilation delivered via ET tube allows the infant to breathe spontaneously at his own rate while ventilator provides a preset cycle of respiration and pressure. Positive end expiratory pressure via ET tube. The ventilatory pressure or volume limiter provides an increased PEEP during the expiration to prevent alveolar collapse. Residual airway pressure is maintained. Continuous positive airway pressure is delivered by a mask or nasal prongs used in spontaneous respirations to improve oxygenation by preventing collapse of alveoli and increasing diffusion time. Synchronized intermittent mandatory ventilation allows the infant to breathe spontaneously between mechanical breath. In assist or control mode, mechanical breaths are delivered at a regular rate if spontaneous breaths are not detected. Maintenance of normal body temperature, maintenance of fluid electrolyte acid-base balance, metabolic acidosis buffered with sodium bicarbonate, maintenance of nutrition by IV dextro 10% in water usually required, antibiotics as needed to treat infection, constant observation for complications like pneumothorax, disseminated intravascular coagulation, petendectus arteriosus with heart failure, chronic lung disease, care appropriate for small premature neonate and prevent hypotension, maintain a hematocrit of between 40 to 45%. Aggressive, that means offered in the tertiary care centers. The treatment include administered exogenous surfactant into the lungs early in the disease, especially beneficial in very low birth weight baby. May be given preventively to very low birth weight infants at birth. Available preparations are natural and synthetic. Administered through the ET tube. Surfactant replacement therapy. Surfactant replacement therapy is prophylactic surfactant therapy. Infants at increased risk for RDS. Infants of less than 27 weeks of gestational age. and infants with birth weight of less than 1,250 grams. Treatment initiated after the infant stabilized in the delivery room or within 15 minutes of life. Rescue surfactant therapy. Infants moderate to severe RDS requiring ventilatory assistance with an oxygen requirement greater than 40%. Benefits of surfactant include decreased oxygen requirement and mean airway pressure and decreased pulmonary leaks. Complications observed in surfactant administrations are pulmonary hemorrhage, petenclitis arteriosus, and mucus plugging. Nursing assessment with surfactant administration include suctioning delayed for 1 hour or as indicated by the protocol, assess with the delivery of surfactant, collection, monitoring of ABG studies, meticulous monitoring of oxygenation status, pulse oximeter, or transcutaneous monitor. Assess the infant's tolerance to the procedure, increase in respiratory complaints, which will require adjustment to the ventilator. High frequency ventilation, mechanical ventilation that uses rapid rates and tidal volumes near and commonly less than anatomical dead space. Jet ventilator delivers short bursts of gas at high flow. Exhalation is passive. Necrotizing tracheitis is a significant complication along with hypotension pneumopericardium. Oscillatory ventilator delivers gases by vibrating columns of air. Exhalation active. The child appears to shake on the bed, which may be frightening for the parents. Extracorporeal membrane oxygenator or ECMO indicated in infants with reversible cardiac or respiratory failure. ECMO is a modified heart-lung bypass machine used to allow the gas exchange outside the body. Blood is removed from the venous system by a catheter placed in the infranal jugular vein or right atrium. Oxygen is added and carbon dioxide removed with a membrane oxygenator. Oxygenated blood is returned by the way of right common carotid or femoral vein. The infant must be heparinized for the procedure, increase the risk of intraventricular hemorrhage. For this reason, very low birth weight babies, infants, or decreased gestational age are usually not the candidates for the procedure. One nurse and one perfusionist must be present at the bedside at all times to monitor the patient and equipment. The patient will receive paralytic agents such as analgesia and sedation, therefore, vigilant, continuous monitoring is required. Cannula dislodgement or tubing separation will result in immediate hemorrhage. Tubing and cannula must be secured and visible. Administration of dopamine or dobutamine may be required to support the alteration in cardiac output and blood pressure. Blood transfusion may be indicated due to blood loss from the frequent sampling or anemia prematurity. Ventilator support modalities for RDS currently under study: nitric oxide, liquid ventilation, and perfluorocarbon assisted gas exchange. Complications of include complications related to respiratory therapy are air leak, pneumothorax, pneumomediastinum, pneumopericardium, pneumoperitoneum, pneumonia, especially gram-negative organisms, pulmonary interstitial emphysema, PD or heart failure, hypotension, intraventricular hemorrhage typically seen in infants weighing less than 1,500 grams, and DIC. Chronic problems associated with long-term use of oxygen include bronchopulmonary dysplasia, cystic appearance of lungs with hyperinfiltration, obstructive bronchiolitis, dysplastic changes, and pulmonary fibrosis. Chronic respiratory infections like necrotizing enterocolitis, tracheal stenosis, retinopathy of prematurity, and other complications related to the prematurity. Nursing assessment include first review the birth history, Apgar score 1 and 5 minutes after birth, type of resuscitation required, treatments of medication administered, medications or anesthesia administered to the mother during labor, estimated gestational age of the baby, maternal history, contributing factors or complications. Carefully assess the infant's respiratory status to determine the degree of respiratory disease, determine the degree and severity of retractions, count the respiratory rate for 1 full minute, not the level of activity, and determine if they are regular or irregular. Identify periods of apnea, length, and type of stimulation necessary. Listen for expiratory grunting or weaning sound from the infant when coached. This indicates an attempt to maintain PEEP and prevent alveoli from collapse, not nasal flaring, not cyanosis, the location, improvement with oxygen, auscultate the chest for diminished breath sounds and presence of crackles. Determine the infant's cardiac rate and rhythm. Count the apical pulse for 1 full minute, not the irregularities in the rate or bounding pulses. Observe the infant's general activity, lethargic or listless, active, and response to stimuli and infant's cry. Assess the skin for cyanosis, jaundice, mottling, paleness, grayness, and edema. Nursing diagnosis include impaired gas exchange related to the disease process, imbalanced nutrition less than body requirement related to the prematurity and increased energy expenditure on breathing, ineffective thermoregulation related to the immaturity, impaired parenting related to the separation from neonate to hospitalization. The nursing actions to promote the adequate gas exchange are have emergency equipment readily available for use in the event of cardiac or respiratory arrest, institute cardiopulmonary means cardiorespiratory monitoring to continuously monitor the heart and respiratory rate, administer supplemental oxygen, incubator with oxygen at prescribed concentration, plastic hood with oxygen at prescribed concentration when using a radiant warmer, CPAP if indicated using nasal prongs or ET tube, assess with ET intubation and maintain mechanical ventilation as indicated, measure oxygen concentration every hour and record. Monitor ABG levels are appropriate. Obtain a sample of blood through indwelling umbilical line, arterial puncture or capillary puncture. Capillary gas analysis for monitoring PCO2 and pH but not PO2. Institute pulse oximetry if available for continuous monitoring of blood arterial oxygen saturation. Avoid using adhesive to secure the sensor when the infant is active. Rapid snuggle enough to reduce sensitivity to movement but not tight enough to constrict the blood flow. If transcutaneous PO2 monitor is used, reposition of the probe every 3 to 4 hours to avoid burns caused by the heating the probe to achieve sufficient arterialization. Observe the infant's response to oxygen. Observe for improvement in color, respiratory rate and pattern, and nasal flaring. Note the response by improvement in arterial or capillary blood gas levels. Observe closely for apnea. Stimulate the infant if apnea occurs. If unable to produce spontaneous respiration, which stimulation within 15 to 30 seconds initiate resuscitation. Position the infant to allow maximum lung expansion. Prone position provides for larger lung volume because this position of diaphragm decreases energy expenditure and increases the time spent in quiet sleep. However, it may be contraindicated due to placement of umbilical catheter. The risk for sudden infant death syndrome is increased, but infant is continuously monitored. Change the position frequently. Suction as needed because the gag reflex is weak and cuff is ineffective. Try to minimize the time spent on procedures and interventions and monitor the effects on respiratory status. Infant undergoing multiple procedures lasting 45 minutes to 1 hour to have show moderate decrease in PO2. Decision to suction should be based on assessment of the infant's auscultation of the chest, decrease in the oxygenation, excessive moisture in the ET tube, and irritability. Nasopharyngeal tracheal ET tube suctioning should be done gently, quickly, 5 seconds or less, with intermittent suction applied as the catheter is withdrawn. To prevent hypoxemia, observe oximeter before, during, and after the procedure. Suctioning of ET tube is done to maintain a patent airway. The practice of inducing a catheter into the tube until the resistance is met and then withdrawn has been shown to cause trauma to the tracheal wall. Instead, the suction catheter should be pre-measured and according to the size of the infant's ET tube and length documented. When suctioning, do not insert the catheter beyond this predetermined length. This will prevent damage to the mucosa. Observe for complications of suctioning like bronchospasm, vagal nerve stimulation, bradycardia, hypoxia, increased intracranial pressure, trauma to airway, infection, and pneumothorax. Very low birth weight baby and extremely low birth weight neonates cannot tolerate percussions and vibrations. Tender bend position is contraindicated in premature neonates and may result in increased intracranial pressure. Record all nursing observations. Promote adequate nutrition hydration. Further, administer IV fluids or enteral feedings as ordered and observe infusion rate closely to prevent fluid overload. Observe IV sites for infiltration or infection. Use meticulous techniques to prevent sepsis. If umbilical artery catheter is in place, observe for bleeding. Provide adequate caloric intake 18 to 120 kilocalorie per kg per hour to the following. Nasovaginal tube best tolerated by very low birth weight neonates. Nasogastric tube or parental nutrition like D10 hyperalimentation fluid usually required, especially in the acute phase of the illness. Monitor the hypoglycemia, which is especially common during the stress. Maintain serum glucose greater than 45 mg per deciliter. Monitor intake and output closely. Include amount of blood drawn. Small infants can anemic due to frequent blood sampling. Apply urine collection bag to obtain sample of urine and measure specific gravity periodically. weigh the infants daily and record it. Maintaining thermoregulations, provide neutral thermal environment to maintain infants' abdominal skin temperature between 98 to 97 to 98 degree Fahrenheit to prevent hypothermia, which may result in vasoconstriction acidosis. Adjust incubator or radiant warmer to obtain desired skin temperature. For infants weighing less than 1250 gram, radiant warmer should be used with caution because increased water loss and potential for hypoglycemia. Prevent frequent opening of the incubator. Ensure the oxygen is warm to a temperature of 87.6 to 93.2 Fahrenheit with 60 to 80% of humidity. Encouraging parent attachment. Identify the factors that may prohibit parents' visitation and communication like geographic distance, lack of transportation, care of siblings, employment restrictions, economic issue, lack of telephone in the home, fear, refer to social service or assistance and interventions if required. If the neonate has been transported to a tertiary care center, immediately after birth, send the mother a photograph of the neonate. Call the parents daily to update them on the infant's condition until they are able to visit the child. Emphasize the positive aspects of the infant's status. Refer the child by his first name when speaking with the parents. Prepare the parents for neonatal intensive care unit environment and how the child will appear before their first visit. Assess the parents for the participate in the child care as possible. Allow the parents to hold the infants as soon as possible. If the mother plans to breastfeed, assist her with pumping and use the breast milk to feed the infant when the enteral feedings are initiated. If the infant has siblings, provide the parents with information on how to discuss infant's illness with them. If not, if the unit policies allow the situation is appropriate, encourage sibling visitation with adequate preparation. Provide the parents with information concerning the disease process, expected outcomes, and usual course of an NICU stay. Encourage the parents to ask questions and participate in the care plan. Help the parents to work through their distress at the birth of a premature child. Assess the parents to support mechanisms like grandparents and friends. Family education health management include prepare the family for long-term follow-up as appropriate. Infants with the BPD eventually go home on oxygen therapy. Stress the importance of regular health care, periodic eye examination, and developmental follow-up with the parents. Ensure the family receives information on routine baby care. Before discharge, parents should feel comfortable in their ability to care for the infant. Referrals for home nursing visits should be completed and the physician identified for the follow-up care. Evaluation of nursing care include expected outcomes are respiratory rate within normal range for the age pattern, regular and unlabored, tolerates enteral feedings well, weight gain noted, maintains the temperature within the normal limits. Means parents interact with the infants, participate in the care, and ask appropriate questions. Thank you.